I'm Simon Craig. I'm a paediatric emergency physician working at Monash Medical Centre in Melbourne. Do a bit of academic work, so I'm an adjunct clinical professor in the Department of Paediatrics, and I'm a member of the College of Emergency Medicine. When COVID-19 came about, there was a lot of concern about healthcare provider safety. And in particular, there was concerns around what we would do in the setting of a cardiac arrest. There were worries that we would be exposed to coronavirus and we'd get sick, and there were questions about which sort of PPE we should wear and which things were safe to do and which things weren't safe to do. The things that we were trying to do was to try and ensure that people did the right thing for the patient but kept themselves safe. And the traditional approach to a cardiac arrest is, they always talk about Dr. ABC and danger before you do anything else, but essentially people just used to rush in and do stuff. Now there was a recognition that people wouldn't be keen to do that and shouldn't be doing that, but at the same time, still trying to ensure that important things were done in a timely manner. So there's that balance of, well, what can you do right now? What can you do if you're wearing airborne PPE? What things shouldn't you be doing? And what things should you be modifying? So really, we're trying to balance rapid response to a life-threatening emergency, but at the same time keep people safe. The process was interesting. There were obviously a group of clinicians in the room, but some evidence experts as well. There was a lot of literature work done in the background and trying to bring together the different guidance that had come out from places like the UK, the USA, ILCOR, as well as our college guidelines, the intensive care college guidelines, and so on. So there was a large number of recommendations that were sort of put together and tabled and then lined up to see where there were agreements and disagreements. And there was a series of meetings over a number of weeks to try and get consensus of the different aspects. I think the hardest thing about coming to a consensus is that there's very little evidence for any of this. So you're essentially left with opinions one way and opinions the other way, and sometimes there'll be strongly held views in one direction, strongly held views in another, or one international guideline will say do this and another one will say do that. So there was lots of discussion, and I think the guidance sort of reflects that in some areas. So, for example, we've got a statement about compression-only CPR, and we think that's completely fine. But then, whether you should be wearing a mask, whether the patient's face should be covered, there were sort of varying opinions on that. And so some of the things that we really couldn't get consensus on was sort of left as an option. So you can do this if you like, or if you're worried, but if not, then it's probably okay. And, recognising that there are people that clearly have coronavirus and you're particularly worried about them, and then you've got people that have got suspected coronavirus, and then you've got people who are just come in off the street and you've got no idea what the history is. So, trying to manage and navigate all those scenarios. And as an emergency doctor, I'm looking at it from the point of view of, someone's just collapsed in the waiting room and we don't know who they are or what's going on. Whereas the people working, say, in an intensive care environment or an inpatient ward would often know the history of the patient and whether they had coronavirus and probably would already be ready to do that. So I think at the time when we put it together, there were varying opinions depending on where we were working in the hospital and what we thought we'd be faced with. These guidelines are not static, and obviously there's so much research going on with coronavirus and all the different things that are happening, and there's different discussions about which PPE we should be using and whether particular procedures are aerosol generating or not. So as with all of these other parts of the guideline, they're living guidelines. They're going to be reviewed every month, and we just try and keep on top of them and update them as we can. I suppose at the very fundamental level, there's what do you do right now? What do you do if you've got lots of equipment? But then also stepping back and thinking about, well, how is the system going to work and what changes do you need to make? So briefly, we've got one flowchart looking at basic life support in the community, where you may or may not have a very trained healthcare provider, but they just need to get started and do the basics. Then we've got cardiac arrest in the healthcare setting, where obviously you've got a team of people, you've got more equipment, you've got more options of things to do, and you've probably got more considerations around PPE. But then stepping back from that, you've also got preparation. So, is resuscitation appropriate? What sort of training are you doing? Where should you be doing the resuscitation? So part of it is that flowchart is looking at the systems level and how things are set up, but also how you would run a resuscitation in terms of some of the practicalities. Children aren't quite the same as adults when it comes to cardiac arrest. They're much more likely to have a cardiac arrest due to respiratory illness and need breathing support as the fundamental part of a cardiac arrest management. Whereas adults, we've essentially gone down a compression-only CPR to start with. Now, that probably isn't quite suitable for children, but there's ongoing work that we need to do to look at paediatric cardiac arrest. These guidelines were really brought about because we weren't sure what to do and we were worried about what to do in the context of a cardiac arrest. So the idea of the guidelines is to provide clear step-by-step process of what you can and can't do to keep yourself safe and still do the right thing for the patient.